All right, let's talk about one of the most high-stakes, high-pressure areas you're going to face on the NCLEX RN exam, respiratory disease. When these questions pop up, the board isn't just testing what you know, it's testing how you think, how fast you can act when everything is on the line. So let's just dive right in.
And really, it is that simple. These are not just some academic trivia questions. The NCLEX is asking you one fundamental thing. Can you keep this patient breathing? In other words, can you make sure they survive?
And that's the hard reality, both in the hospital and in that testing center. The stakes for the patient are tied directly to the stakes for your score. If you miss those subtle little cues early on, things can go downhill for everyone fast.
This is probably the most crucial point to get. Look, memorizing a textbook chapter on pneumonia, that's not going to cut it. The NCLEX wants to know your priority action. It's a test of your judgment, your decision-making, not just your memory.
And that's exactly what we're going to walk through right now. This is not a full-blown lecture. Think of it as a peek behind the curtain, a look inside a strategic framework designed to build your clinical judgment so you can tackle these problems exactly the way the board wants you to.
So, let's be real for a second. Why is this topic so incredibly tough for so many nursing students? What are the common mental traps that just trip people up over and over again?
Does any of this sound familiar? You've got conditions that sound almost identical, symptoms that seem to overlap everywhere, and you're trying to pull up some list you memorized from a textbook when what you really need is a way to see the bigger picture. If that's you, you're not alone. These are the exact hurdles we see all the time.
And right there, that's the solution. It is not about cramming more facts into your brain. It's about having a better system, a structured way of thinking that helps you cut through all that noise and get straight to the priority. So, let's take a look at how a real decision-making framework can organize these super complex topics into clear, clean, decisive patterns that you can actually use.
Okay, first up, chest injuries. This is where things can get confusing and fast. But what's the fundamental difference here? Well, our framework starts by simplifying it. Where's the air coming from? An open pneumothorax means air's coming in from the outside. You've got a hole in the chest wall. A closed pneumo means the leak is from the inside, from the lung itself. It's a simple distinction, but it drives every single one of your interventions.
Now, what about when things get really bad? When you see this cluster of signs, that severe chest pain, the patient turning blue, they can't breathe, and their heart is racing, your internal alarm bells have to be screaming tension pneumothorax. These are the absolute red flags for a true life-or-death emergency.
So let's put it into practice. You've got a trauma patient. All of a sudden, you see their trachea shift to one side, and their blood pressure absolutely tanks. What is your first move? What do you do right now? Just keep that question in the back of your mind.
Next, acute respiratory failure. You got to know this isn't just one single thing. The framework immediately splits it into two core problems. Is this an oxygenation problem, what we call hypoxemic failure, or is it a ventilation problem, where you just can't get that CO2 out? That's hypercapnic failure. Getting this distinction right is everything.
So think about this scenario. Your patient's getting really restless, maybe a little confused, and you see on their labs that their CO2 level is climbing. What does that pattern tell you? What is the story that's unfolding right in front of you?
And then you have the big one, ARDS, Acute Respiratory Distress Syndrome. This is a totally different kind of failure. The absolute #1 key identifier is something called refractory hypoxemia. All that means is you're giving them tons of oxygen, but their O2 sats just won't come up. That, plus these other signs, that's the classic ARDS picture.
Which of course leads to the kind of critical thinking question the NCLEX loves to ask. Why? Why in ARDS can you crank the oxygen all the way up and still not fix the problem? The answer isn't about the oxygen, it's about the lungs themselves.
Okay, let's switch gears to airflow obstruction. You've got asthma and COPD. They can look super similar on the surface, right? But the defining difference is one word: reversibility. Asthma is considered a reversible problem. COPD, on the other hand, is irreversible. That single word changes your entire management plan.
So here's your classic NCLEX setup. A patient is wheezing, they've got a long history of smoking, and you notice that barrel chest. You're thinking, okay, this has got to be COPD. So what vital sign, one that's specifically related to the interventions you might give, do you have to monitor with extreme caution?
Now, let's jump to infections. For pneumonia and influenza, the board wants to see if you can think like a public health nurse. Can you spot the difference between viral and bacterial patterns? Do you know who's most at risk? And maybe most importantly, do you know the correct isolation precautions to keep everyone safe?
So picture this. An elderly patient comes in. You hear crackles in their lungs, they have a fever, and all of a sudden, they're confused. This is a potentially deadly combination. So what's your number one priority? What do you do first?
Pulmonary embolism. This one is all about speed and pattern recognition. It often kicks off with that sudden, sharp chest pain, the kind that gets way worse when they try to take a deep breath. Then, boom, they're acutely short of breath, breathing super fast. Then they get restless, their heart rate skyrockets. And if it keeps going, that blood pressure will drop. It's a deadly sequence, and you have to see it coming.
Okay, so you have a patient who just got out of surgery. Everything was fine, and now, suddenly, they absolutely cannot breathe. What's the very first diagnosis that should flash through your mind? The patient's history, their risk factors, is key here.
And let's not forget tuberculosis. For the NCLEX, TB is all about one thing: safety. It's about knowing the exact isolation precautions, understanding how critical medication adherence is, and getting the massive public health implications of this disease.
And that brings us to a fundamental safety principle you have to know. Why isn't a negative pressure room just a nice to have? Why is it an absolute non-negotiable requirement for a patient with active TB?
You know, we've just zipped through 7 different conditions, and it probably feels like a ton to remember. But what if I told you it all really boils down to one single, powerful question?
This right here is the heart of a unified system. In any respiratory scenario, your first thought has to be, is the airway stable? Because every single disease we've talked about is just a different way of threatening that stability.
Chest injuries, things like a pneumothorax or a flail chest, they threaten the physical structure of the chest.
Asthma and COPD, what are they doing? They're threatening the airflow through the tubes.
Pneumonia and the flu, they fill up the lungs with gunk, and that threatens gas exchange at the alveolar level.
And a pulmonary embolism, it's not an air problem, it's a blood flow problem. It's threatening perfusion. And ARDS, it creates so much chaos with inflammation and fluid that it just completely overwhelms the entire system of oxygenation. You see? It's not just a random list of diseases, it's a unified system of threats.
And this is why our focus isn't on memorizing lists of facts. It's about training your clinical judgment. We don't just teach you about diseases. We train you to recognize the emergency when it's happening, to prioritize what matters most, and to make that safe, smart clinical judgment call every single time.
And this, right here, gets to the very soul of the NCLEX. You're not looking for the answer that has the most details or sounds the most academic. You are looking for the safest action for your patient in that exact moment. That's it.
So this was just a quick preview of how you can start to think about this critical topic. If you're ready to see the whole thing, the complete framework, all the answers, the deep dive rationales, it is all waiting for you right inside Exam Coaches.